we're going to switch now to talk about ECT, and I will spare you much of the discussion about the historical irony of the situation of contemporary ECT in Italy, where it was invented, and Dr. Shorter will be talking to you about that later this morning. Here are my disclosures. And I'd like to start by quoting from Michael Bersinger, a paper that came out just a few years ago. Despite positive scientific evidence, the therapy, that's ECT, is often approached with reserve that cannot be explained rationally. So if ECT were a new, interesting, sexy treatment, and people looked at the efficacy data today and didn't have all the baggage of ECT's history, it would be hailed as one of the best treatments in all of medicine. I learned to do ECT in 1978 in California. So I've been doing, next year will be the 40th anniversary of my doing ECT, so I've been doing it half of the time that ECT has been available in history. And what I've tried to do in my career is to keep ECT in the mainstream of American psychiatry, and therefore hopefully have some influence on psychiatry in other countries around the world. But my message to you today is very simple, and it is that ECT should be considered a standard part of contemporary psychiatric medicine. It should be a routine treatment. And the title that I have for my talk, Revered and Reviled, shows that people think about ECT in extremes, and we need to moderate that. So it shouldn't be revered, nor should it be reviled. It should be accepted as an important standard part of contemporary psychiatric medicine. Now, part of the problem is that we have not done a very good job of giving ECT a good name. So here's a quote from what was originally published in The Lancet in 1981 anonymously, but turns out to have been written by Chris Freeman after an audit of ECT services in Great Britain. And you're going to hear a lot about this from Linda this afternoon, about the effect of this survey in 1980 showing that ECT services in Great Britain were neglected. And ECT was done by the junior registrar in the basement of psychiatric hospitals in Great Britain with outdated machinery and with very few resources. So Dr. Freeman said, it is not ECT which has brought psychiatry into disrepute. Psychiatry has done just that for ECT. But I'm glad to say that 40 years later, the situation is quite different, and around the world there have been efforts that have been spearheaded by our colleagues in Great Britain to make ECT practice better and better. So there's a large evidence base about ECT being safe and effective. This is the scientific evidence base. And what I do periodically is go to PubMed and look at how many citations there are. You have to look up both ECT and electroconvulsive because ECT stands for a number of other things in different medical specialties. So I did this 10 days ago, and here's the world's literature on ECT. If you remember nothing else of what I say this morning, one of the things that I like to tell people is that if you want to be up to date with the ECT literature, it will take you 2 minutes a day to go to PubMed and type in ECT, then type in electroconvulsive, and see the latest articles that have been written about ECT. And the literature is added to approximately 3 to 5 articles a week. So if you were to, with your coffee tomorrow morning, go to PubMed and look this up, you could be, with 2 minutes every day, completely up to date with all of the ECT literature in the world. So I recommend this as a study habit to everyone. It doesn't have to be ECT, but since we're an ECT group, this is what it's about. If you have a particular interest in something, you can absolutely stay up to date easily by doing that. So let's locate ECT in the larger domain of depression. So here you see on the left, depression affects a huge number of people, an estimated 120 million people around the world. Although the data are not great, we believe that about 1 million people around the world get ECT each year. And in the United States, it's approximately 100,000 people, so probably about 1 million ECT procedures a year in the United States. I recently left Mount Sinai to open up an ECT practice in a small hospital in Brooklyn, New York. And it's amazing how much demand there is for ECT in the United States. And it's likely that we do more ECT in New York City than you do in all of Italy. And again, one of the points that I like to make is that ECT needs to be what I call right size. We need to be doing an appropriate amount of ECT such that the most severely ill patients are not neglected and get the serious treatment that they need. Going back to JAMA, this I bring your attention to is from the August issue this year, August 2017 of JAMA. It's an editorial by Harold Sackheim, whom you know is one of the great ECT researchers of the last several decades. And I just bring your attention to the title that summarizes his editorial. Modern electroconvulsive therapy, vastly improved, yet greatly underused. And part of the problem continues to be not only the fact that we fail to supervise ECT in the profession, but there's active anti-ECT propaganda promulgated mostly by the Church of Scientology with its very deep pockets. And so this continues to be a huge problem for our field, and they continue to try to promulgate the stigma about ECT. So let me just give you a little general background, and then I'm going to show you some data from our studies that we've done over the last several decades in our group. So it's clearly the weirdest treatment in medicine. Who would have thought that inducing a cerebral seizure would have such a therapeutic effect? So that's the first hurdle that we have to get over. People think it's a very strange thing to be introducing electricity into people's brains. And at least in the United States, it's the second most controversial treatment in medicine after...
Psychosurgery.
Not psychosurgery, no.
Abortion.
Abortion, yes. So, psychosurgery is probably third, okay? It remains the gold standard acute antidepressant and antipsychotic. So ECT, as you were beginning to hear Dr. Sands talk like lithium, is a mood stabilizer to an antipsychotic. And it's around because of its unsurpassed efficacy and speed of response for serious mood and psychotic disorders. Here's a table that I put together. On this side of the table you see these are remission rates for the various treatments that we have for depression. And I basically do it to compare and contrast ECT's remarkable remission rates with those of things like repetitive transcranial magnetic stimulation. These data here are the STAR-D data for pharmacotherapy, and in the modern era, there's been so much excitement about ketamine that this has to be put in here. But I submit to you that these things are not in contention for competing with ECT, particularly for the serious type of patients for whom ECT is indicated. So I said I wouldn't belabor this, so you know it was invented in Rome. The problem was that originally it was done without general anesthesia, which there is a current euphemism for. Euphemism is a word that means you're trying to gloss over something and make it look okay. So it's called unmodified ECT if you don't use anesthesia. But in developed countries since the 1950s, ECT has been performed with full general anesthesia. That's a fact that many of your colleagues probably don't understand, that ECT is done under full general anesthesia. Muscle relaxation and oxygenation to protect the brain and the heart during the treatment. And as I said, millions of people have received ECT successfully. This is a cartoon from the New Yorker. This is a dig at psychoanalysis. Well, I do believe, I do have this recurring dream that one day I might see some results. So ECT is not for the walking worried, and it doesn't take 6 years to work like psychoanalysis sometimes does. So here's a slide where I show you a continuum of severity of depressive illness, from mild, where psychotherapy might be appropriate, to moderate, where you would add an antidepressant, to the severe range, where ECT becomes a consideration. But even in the severe end of the spectrum, there are gradations, which are shown here on this slide. So ECT starts being appropriate for people when their depression is disabling, and sometimes, if they are urgently psychotic or suicidal, ECT becomes urgently indicated. And in rare cases of patients with catatonia or neuroleptic malignant syndrome, ECT may in fact be indicated because the patient has a medical emergency. But this is the main area where we are talking about ECT for severe depression. So just very quickly, the fundamentals are it's an induction of a generalized cerebral seizure under full general anesthesia and muscle relaxation. It's typically given 2 to 3 times a week. In the United States, it's typically done 3 times a week. In most other countries, twice a week until the symptoms remit. Current ECT techniques, there are options, including right unilateral, bilateral, and bifrontal electrode placements, and I'll talk a little bit about the choice amongst those because they have slightly different rates of efficacy and different side effect profiles. And then I'll show you some data from the newer type of ECT called ultra-brief pulse right unilateral ECT, which is becoming more and more standard. This is just a picture to show you that modern ECT can look much better than it did in the old days. So one of the ECT devices allows you to use disposable stick-on stimulus electrodes. This is also the only known medical advantage of male pattern baldness, that you could actually get these 2 electrodes stuck on there. And you can see that I would be a fabulous candidate for right unilateral ECT, despite the fact that I am left-handed, and we could talk about that a little bit too. So one of the advances in ECT is the type of stimulus that we now have in modern ECT devices. So in the old days, it was sine wave that clearly causes more cognitive disturbance than either brief or ultra-brief pulse waveforms, which are now the standard of care for modern ECT devices. Apparecchio per elettroshock. This, as you know, is going to be shown again by Dr. Shorter, so I won't belabor this, but it does say here, nessun pericolo, nessuna intolleranza. So, yes.
No cost.
Right, no cost to operate. So, even in the earliest days, people were making exaggerated claims about ECT. ECT is not perfect, so it's very important that we don't exaggerate its benefits, and we put them in context. But here's how ECT devices have evolved over the last several decades, and these are the two most commonly available ECT devices. And as you can see, you can, to either device, attach a computer monitor so you can watch the seizure develop in real time. So that's what contemporary ECT looks like. And here you see a well-developed ECT seizure being viewed real time during the treatment. This is what the printout of the treatment looks like. So this is 2 channels of electroencephalogram. This is left hemisphere, right hemisphere electroencephalogram. This is monitoring the motor portion of the seizure from the right foot. So in modern ECT technique, you put a blood pressure cuff around the patient's right foot to exclude the muscle relaxant from the foot so that you don't completely paralyze the patient. And you can see the motor manifestations of the seizure in the patient's beating right foot. And that's measured there. And then on the bottom, you have the patient's cardiogram. So this is the seizure going on. You can see in seconds here, the motor part of the seizure ends in 40-something seconds, and that's quite typical. And it's also typical that the motor part of the seizure ends first. And then this is the end of the cerebral seizure as the brain goes into a post-ictal period of electrical quiet. So that's what you do to monitor what you've done during the treatment in modern ECT. And in fact, the most important part of this is seeing that the seizure has actually stopped, because you want to make sure that the patient is not continuing to have a seizure or maybe developing a tardive seizure. So back to the great Food and Drug Administration and all its wisdom in the United States. So here are what the FDA currently approves as, they call them cleared indications for use for ECT devices. And this is actually a very good list. It's comprehensive, and it's what most practitioners would say ECT should be used for. So this is analogous to the FDA saying what are on versus off-label indications for a drug. So they also monitor devices, and this is the analog of that. Unfortunately, they are considering getting rid of indications 2 through 6 and only considering ECT to be on label for refractory depression in adults. So that will get rid of the use of ECT in schizophrenia, in mania, and any of the children who need ECT under the age of 18 would be getting it off label. So if this happens, there could be a seriously chilling effect on ECT practice in the United States. Now, the FDA works very slowly. We like to say it works at a glacial pace. So hopefully it will be several years before they actually come out with their ruling. But that, unfortunately, is on the horizon. So let's just talk for a few moments about how to think about for whom ECT is indicated. And one of the important points to understand is that severe depression is not exactly the same thing as treatment-resistant depression. People can have treatment-resistant depression because they have the wrong illness. So if they have comorbidities of personality disorder, anxiety disorder, substance abuse disorders, bad life circumstances, all of these things can make depression difficult to treat, but it doesn't mean it becomes appropriate for ECT. And in practice, if you're an ECT practitioner, you get referrals from other psychiatrists who say, well, I've tried everything else, it must be time for ECT. That is not the way to prescribe ECT. This is sort of backing into it in a negative way, and you really should always approach it from the other end in a positive way, that the patient has the right type of depression and it's severe enough for them to need ECT. So here are the things that I like to say are indicative of the best type of ECT responder. So they have to have severe depression, they will typically have a family history of mood or psychotic disorder, and they will have an episodic type of illness. If the patient walks into your office and says, "I've been depressed since I was 5 years old," that is not likely to end up being a good candidate for ECT. And just to make the point about what are episodic versus continuous illnesses. So unipolar depression and bipolar disorder are clearly episodic illnesses. And what ECT does is treats the current episode of the illness. And it treats it better and more completely and more quickly than almost any other treatment that we have in psychiatry. But ECT also has an effect on illnesses that are continuous, including schizophrenia, Parkinson's disease, OCD, and as you're going to hear about this afternoon, self-injurious behavior and autism. But if you do ECT in these conditions, you wouldn't expect it to last forever. So if you do that, you'd expect it to have a beneficial effect that would decrement over time and need to be reinforced probably with maintenance ECT. I want to make another point about prejudice against ECT and the cognitive issues about ECT. So the biggest problem with ECT in the last 30 years is that people think it has a terrible effect on memory. And it does have a bad effect on memory, but that should not be the deal-breaking issue with ECT. And I think we need to talk about it in a way that is fair to the treatment. And in medicine, when we talk about safety issues, we should be talking about the risk of death or physical injury. And cognitive impairment does not fit into that, and I think we ought to be talking about it as a tolerability issue rather than a safety issue for ECT. And I think this is actually more than a semantic issue. So ECT is great, but here are its shortcomings listed on this slide. So we talk about medical risks of ECT, but we can get rid of that pretty quickly because ECT is remarkably safe, and there's some very good new data about the mortality rate of ECT, which is extremely low. It is the safest procedure that is done under general anesthesia. So that's, for most people, that's not really the issue for ECT. The cognitive effects are a consideration, as I mentioned, with the biggest problem being the erasing of recent memories. And much of the work that I'll tell you about in the next few minutes is an attempt to make ECT better and to decrease its cognitive effects. And as we have alluded to, it doesn't prevent future episodes unless you do maintenance ECT, and I'll show you some of our recent data on that. And for some reason, post-ECT rates, relapse rates are higher in contemporary psychiatry than they were decades ago. So when I started doing ECT in the 1980s, it was very typical to get a patient who would have a psychotic depression, have ECT, and stay well for 5, 10, 15 years. Now that is much less likely to happen, and we don't quite understand why. It's probably a combination of destabilization of the illness from multiple medication trials, as well as doing a possibly less intense form of ECT. So here's the biggest problem with ECT. It causes some retrograde amnesia, and what it does is it makes the patient somewhat confused for a few weeks during the course of the treatment, and it also erases some of the most recently formed memories. So the memories that are most recently formed are the ones that are most vulnerable to being erased by the treatment. But again, for most people, this is a nuisance, and it shouldn't stop somebody with a life-threatening illness from getting the definitive treatment that they need. And very importantly, the techniques of ECT, not just right unilateral, but even bilateral ECT done with brief pulse today, causes far less memory impairment than it did decades ago. here is a meta-analysis done by Declan McLaughlin's group from Ireland, looking at the cognitive effects of ECT in all of the world's literature. And their conclusion is that the cognitive effects are mainly limited to the first 3 days post-treatment. I think that's a little bit optimistic, but it does make the important point that almost all of the cognitive effects of ECT are transient in most patients. Now, there are always going to be outliers, but a rare outlier should not drive the discussion about the appropriateness of ECT, in my opinion. So we've seen that ECT is remarkably safe, it's remarkably effective, and that the tolerability, particularly the cognitive issues, are what need to be improved. And so this is a schemata of ECT when it is optimized so that the tolerability gets to being where the efficacy and safety are. And that's basically been the theme of much of the ECT research of the last 30 years, some of which I'm going to show you about. A lot of people are very concerned that we are using a treatment that we don't know the mechanism of action of. Same for lithium, as you mentioned before. There are many things in medicine that we don't understand exactly. And so again, ECT should not be singled out because we don't know how exactly it works. The good news, however, is that I believe that in the next 5 to 10 years, we will know a tremendous amount about how ECT works. And we used to have fairly primitive ideas that perhaps the antidepressant effect was somewhere in the frontal lobes and that the cognitive effects were all in the hippocampus. This is just a cartoon to make the point that I think it's a much more nuanced view and that there are things that happen in the limbic system that relate both to efficacy and to side effects. I'm not going to go into any detail here, but I'm going to mention that these are the main theories of mechanism of action of ECT. And what I believe is that in the next few years, we're going to prove that ECT works primarily because, similar to lithium, but more powerfully, it has tremendous neurotrophic effects. And this has been known for several decades. This is a rat study. This is the hippocampus of a rat after the animal analog of ECT, which is called ECS, and it causes neurogenesis in the dentate gyrus of the hippocampus here. That's been well known. But nowadays, this is probably the first big paper from 2013 in PNAS by Ducart, showing that ECT increases gray matter volume in the hippocampus and in some parts of the cortex, but it has a bidirectional effect. Some areas of the brain are increased in gray matter volume, some are decreased. And basically, I think what we're going to find is that the atrophic areas in the depressed brain are normalized by ECT, and we'll be able to prove that. So here's some data from the UCLA group. This is a publication by Joshi et al. In biological psychiatry, looking at increase in hippocampus and amygdala in patients who get ECT. And in fact, if you had gone to PubMed last week, you would see that there is a new meta-analysis of hippocampal volume with ECT, and it's pretty good data showing that ECT clearly increases the size of the hippocampus. Now, we don't know exactly what is doing that and how long it lasts and what the implications are, but this is a start. And I think in the next few years, this neuroimaging data is going to become compelling. This is just another very recent study that I found. And as with many neuroimaging studies, these are small cohorts. This is fewer than 15 patients, but just showing increase in gray matter volume in temporal lobe structures with ECT. And also, I would like to allude to the fact that finally, neural connectivity is beginning to be investigated with ECT. So this is a study also from the UCLA group, the details of which are not important, but it's one of the first studies of neural networks in ECT, and I think we're going to be able to ascertain exactly what ECT does to neural connectivity in the next several years. And finally, just in this section, there's a tremendous ongoing basic science work with animal models and ECT. And it's clear that ECT has profound effects on neuronal cells, particularly in the hippocampus. So a lot of very important work. So rather than saying we don't know how ECT works, I think we should now say ECT has potent neurotrophic effects, and we know a tremendous amount about what ECT does to the physiology of the brain. So now I'm just going to review for you quickly some of the data of the large-scale studies that I have had the privilege to be part of over the last 20 or so years in the United States. So in the late 1990s, Max Fink and Harold Sackheim helped us to put together a consortium of academic medical centers so that we could add to the evidence base of ECT with some adequately large cohort studies of important issues in ECT. So that resulted in the group that has come to be known as CORE, the Consortium for Research in ECT. This is the first study that we did that was published in the archives in 2006. And we did 3 times a week bilateral ECT for unipolar depression in a mixed age adult population, and then followed them in a continuation phase where they got nortriptyline and lithium versus a fixed schedule of continuation ECT and no drugs, so monomodality therapy in phase 2 here. The most interesting data from this study are actually from phase 1. So there was a 64% remission rate overall. If patients were able to complete their ECT course, they had a nearly 90% remission rate. And remission is strictly defined here as a Hamilton of 10 or less on 2 consecutive occasions. We also replicated the frequently replicated finding that patients with the psychotic form of depression do slightly better than patients with non-psychotic depression with ECT. So they start with higher Hamiltons and they end up with lower Hamiltons in the non-psychotic group. So it's part of the theme that the sicker you are, the better you do with ECT. And here are the data from the phase 2 of that first study, in which everything came out exactly the same. So the monomodality fixed maintenance ECT had about a 50% or so relapse rate, as did that particular combination of pharmacotherapy. Our group then went on to do what we had hoped would be the definitive study of electrode placement. So we randomized a cohort of patients. This time we included patients with bipolar disorder to bilateral, right unilateral, and bifrontal ECT. This is published in the British Journal of Psychiatry in 2010. And you see the remission rates layer out as you would expect, with right unilateral being slightly less effective than bifrontal, which is slightly less effective than bitemporal. But even in this cohort of about 200 patients, those differences were not statistically significant. The take-home message is a little bit complicated, though, because it doesn't mean that everybody should get right unilateral ECT. It means that as a first choice, for most patients, right unilateral ECT is only slightly less effective than bilateral. But if it doesn't work, patients need to be crossed over to bilateral ECT. This does not mean that there is no longer a place for bilateral ECT in contemporary practice. And in our practice, about half of our patients get right unilateral, and the other half still get bilateral because they need it. And patients who are urgently ill should have bilateral ECT. One of the other things we were able to show in pooling the data from these first 2 studies, in which we get very large cohorts for ECT, this is a huge number, 700 patients, that people get better very quickly with ECT. So you have over a 9-point decrease in the Hamilton score immediately after the first treatment. So many patients begin to get well with the first treatment, and by the end of the first week, many patients have a dramatic decrease in their symptomatology. And then we went on to do a study in geriatric depression, and these are the last data I'm going to show you, and then we'll finish up with just a few more comments about stigma again. This is a study that was published last year, now 2016, in November 2016 issue of the American Journal of Psychiatry, the PRIDE study. PRIDE stands for Prolonging Remission in Depressed Elderly. So this is a study of geriatric depression. Holly Lisenby was my co-PI on the study, and here are all the people who helped to do this work.